joined by Dr. Lasse Ramo from Finland, and we're going to be speaking to him about the study that he led that was published in JAMA earlier this year, and the title of that being Effective Surgery versus Functional Bracing on Functional Outcome Among Patients with Closed Displaced Humeral Shaft Fractures. Hi, Lasse.
Hi.
Thanks for joining us.
Thanks for asking me.
So I was hoping you could start by telling us why you think it was time to do this study specifically.
If we go back to Sarmiento's paper on 2002 about the humeral shaft fractures treated with the brace and 98% healed, it was kind of something that raised our eyebrows, since we hadn't seen that kind of success in our unit. And basically other papers after that have had also not so great success with conservative treatment. And even though it's quite a common fracture, we looked at the literature and didn't find any good comparative studies. This was 2010 when I came to this unit, and I had a good discussion with my boss after a year when I was a resident here, and we decided that we had to do something about this and decided to do a randomized control trial on these patients. And also, these were the patients we quite often had long discussions how to treat this fracture.
This is an interesting question to me, the surgery versus non-surgery, because it's something that's not necessarily driven by data from the literature, but a little bit driven by surgeon behavior. And you guys mentioned that in your introduction, that despite a lack of high quality clinical evidence, the surgical rate continues to go up.
There are a few papers on this subject, and we've seen a rise in the numbers of surgeries in the States, in the Netherlands, and in Finland as well. Three papers we found about this. It's time to have some evidence to support this trend.
And what do you think is driving that in the lack of high quality evidence, that increasing surgical rate? Do you think that we're, as clinicians, just seeing a higher non-union rate than is in the literature? Is it difficult to watch patients suffer through the first, few weeks of non-operative treatment? What do you think is really driving that?
That's a good question. It's something that the patients might want a little bit more nowadays than they used to do, let's say 20, 40 years ago. So they demand more and quicker recovery, and that might be one reason why some surgeons prefer surgery. We might think that the patients get well quicker if we operate on them, and that might be one reason. And then also I would say cultural things. We think that we've developed as surgeons, and we think that we have better results with modern techniques compared to old school non-op treatment. So those might be the reasons behind these trends we've seen.
Now might be a good chance for you to just refamiliarize us with what your primary outcome measure was for this study and what your findings were.
Yeah, so our primary outcome was DASH, disabilities of arm, shoulder, and hand at 12 months after the fracture, so after the randomization, basically. And our primary outcome was that there was no statistically or clinically significant difference between the patient groups between surgery and functional bracing at 1 year. So it was 8.9 points in the surgery group, and 12 points in the bracing group in intention to treat analysis.
If we could chat about this figure for a minute. In the body of the text, you elaborate on the 1 year DASH scores and how there's no significant difference.
Yeah.
But at 6 weeks, at 3 months, there was a significant difference with clinically important difference. And at 6 months, it was still close to a clinically important difference between the two groups. Some people, I think, might argue that there's an argument to be made for surgical treatment in that 6-month window where people are doing better.
So basically the problem is that if you have several time points as an outcome, then you have a multiple comparison situation. And we decided that at 1 year at least, the situation has to be stable, more or less, and that would be the latest that the patient should feel fine after this kind of injury. One might argue that at least or latest at 6 months or even 3 months, the patient should feel fine. But as we can see from this figure, that even the patients with surgery didn't feel fine at that time, since they have higher points or above the MID compared to scores at 1 year. So basically they didn't do fine at that time point, but they did better compared to functional bracing group. And I think this has implications in shared decision making. You can tell your patients that there's a fair chance that you feel better in the early phase of the recovery, but you will still get better during time, and at 1 year you have similar results no matter what the primary treatment was.
And then your definition of non-union, I'm going to read it out, was no bridging in 3 out of 4 cortices at 3 months, plus clinical evidence of fracture site motion. And that's maybe a little bit different than the traditional definition of non-union, but probably more in line with the way of people are thinking about humeral shaft fractures now.
That was a good discussion in our group as well. When should one deem a fracture, a humeral shaft fracture, non-united? And it's a difficult decision to make, but we thought that earliest at 3 months we can offer operation for a patient if the fracture is mobile and we don't see any callus formation, at least on the 3 cortices. So those were simple decisions to see that those that were operated really had a non-union.
Your crossover rate was about 30% with a 25% non-union rate.
Yeah, it was a surprise to us to see that high rate, but then maybe by chance in the early this year we had this paper by Serrano et al. about from the US, and a big retrospective cohort of 9 academic hospitals from the States, and they were just looking at this specific thing, how many patients with functional bracing end up having surgery, and they had a 29% or 30. So basically just in line with our findings. So it seems that it's quite credible estimation of how many patients end up having surgery if they start with functional bracing.
I thought one of the questions that you asked that was interesting was asking patients how willing they would be to undergo the same treatment, the last line on this table.
Basically, the patients with surgery, they were happy. Basically, those 70% of the patients in the bracing group, they are the ones who healed well. So those who heal well, they are happy. And actually, not all the patients in the surgery group do fine at 1 year. If you go back to the figure, so the outliers are there. So you see that also in the surgery group, there are several patients with very high DASH scores, and still 97% of the patients state that they are willing to repeat the same treatment. So one might argue that people feel that at least they tried, meaning us surgeons, that we tried to help them, but I'm not doing fine, but I would choose again to have this trial of surgery.
Have the results of this study changed your practice?
Nowadays, we tend to give more thorough information to the patients and maybe a little bit higher operation rate. But we looked at our hospital data before this trial, and we found out that actually 50% of the patients with humeral shaft fractures had a primary surgery in our unit from 2006 to 2009. So basically, we've been quite active on operating on these injuries even earlier. But the feeling is that it's gonna be higher after this trial.
We play you guys in hockey, and Finns have a reputation of being pretty tough. And there was only 2 patients that were not tolerating the bracing. Do you think that somewhere where maybe the population isn't as tough, that the crossover rate for not tolerating bracing would be a little bit higher?
Yeah, that's a good question. In Finland, we Finns have this thing called sisu, meaning we have good endurance and tolerate lots of things. So one might argue that you cannot have good external validity for our results. You cannot compare us Finns to other people, but I don't believe that actually. So basically, I think the functional bracing is quite well tolerated if properly advised how to use it. We are not special in that sense here in Finland. In hockey, we are special, but not in humeral shaft fractures.
Anything else that you want to tell us about this before we wrap up?
Yeah, I'm waiting for the results from the Canadian study and from the Edinburgh study as well from the UK. So then I think we have to have another Zoom meeting about meta-analysis.
I think it will be interesting because even if the results are similar to yours, I don't think that it answers in black and white exactly how we should be treating these, other than pointing towards more shared decision making.
Yeah, thanks for pointing that out, because but that's how I think that's how we should approach these problems, that we try to have the best information we can from the studies, and then share this information to our patients, and then make the decision together with them. So life is not black and white, and different patients like more gray, and different patients like more light. So that's we just can give some more information to our patients with these trials.